morning, everybody. I'm Dr. Swathika, Assistant Professor, Department of Biochemistry from Sri Lakshminarayana Institute of Medical Sciences, Pondicherry. Today, we'll be discussing about a very important topic in biochemistry, porphyrias. So, we'll be going through the slides and I will be teaching what is porphyria, what is the mechanism behind the manifestation of porphyrias, all these things. So, we'll move on to the first slide. So these are the topics under which we are going to discuss. Introduction, definition, classification, clinical features, and how do you investigate a case of porphyria and how do you treat a porphyria case. So what is meant by porphyria? The term porphyrin and porphyria are derived from the Greek word porphyrus, which means purple. So basically a porphyrin compound is a cyclic compound which is composed of 4 pyrrole rings connected by methyl bridges. And these porphyrins are nothing but integral components of heme proteins. So what are the heme proteins? Basically there are many heme proteins, out of which the most commonly we encounter are hemoglobin, cytochrome, and myoglobin. So this porphyrin will exist as 4 isomers. Among the 4 isomers, type 3 porphyrin isomer will contribute to heme synthesis. And there are 3 types of porphyrins which are of clinical significance. One is uroporphyrin, second one is coproporphyrin, third one is protoporphyrin. So this is heme synthesis cycle. So you can just see and just make it everything. So here you can see the first one amino acid which is involved in synthesis of hemoglobin is glycine. This glycine will combine with succinyl-CoA under the action of enzyme ALA synthase and the CoA enzyme pyridoxal phosphate to form delta aminolevulinic acid. This ALA will, 2 molecules of ALA will combine to form porphobilinogen. With the help of enzyme ALA dehydratase will undergo dehydration reaction to form porphobilinogen, and the cofactor it is a metalloenzyme and it requires zinc for its action. This porphobilinogen will get converted into hydroxymethylbilane with the help of an enzyme porphobilinogen deaminase, and this hydroxymethylbilane to uroporphyrinogen 3 with the help of enzyme uroporphyrinogen 3 synthase. Uroporphyrinogen 3 will be converted to decarboxylated to coproporphyrinogen 3 with the help of enzyme uroporphyrinogen decarboxylase. This coproporphyrinogen 3 will undergo oxidation reaction to form protoporphyrinogen 3, and again a second oxidation reaction will convert protoporphyrinogen 3 to protoporphyrin 3. And the last enzyme which will convert protoporphyrin 3 to heme is called as ferrochelatase. So heme synthesis, out of this entire reactions, the first reaction and the last 3 reactions will occur in mitochondria. Rest of the reactions will occur in cytosol. So it is a pathway which will happen in both mitochondria and cytosol. So what is porphyria? Porphyrias are a group of metabolic disorders resulting from defects in synthesis of heme in liver or erythroid cells. It is characterized by accumulation of porphyrin and or its precursors and increased excretion of porphyrin and its precursors. It can be either inherited or acquired. So how do you classify porphyria? Based on the site of expression, that is, where does the porphyrin gets accumulated? Based on that, we can divide porphyria into hepatic, erythropoietic, and having both the components, hepatic and erythropoietic. Under this, it will come acute intermittent porphyria, hereditary coproporphyria, variegate porphyria, ALA dehydratase porphyria. Under erythropoietic, congenital erythropoietic porphyria or erythroprotoporphyria, and both porphyria cutaneous tada. Based on mode of presentation of disease, we can classify porphyria into acute porphyria and non-acute porphyria. Non-acute porphyria is also called as cutaneous porphyria. So again, AIP, HCP, variegate porphyria will come under acute porphyria. CEP, EPP, and porphyria cutaneous tada will come under non-acute porphyria. Now we'll see in detail about each porphyria. Acute intermittent porphyria is autosomally dominant in inherited disease and there is a mutation in HMB gene. So because of this HMB enzyme synthase enzyme, hydroxymethylbilin synthase enzyme is defect. It is also called as porphobilinogen deaminase or uroporphyrinogen 1 aminase. So what happens because of this 4-porphobilinogen, which is getting converted to hydroxymethylbilin, will not happen. So because of this, there will be accumulation of porphobilinogen. What are the precipitating factors which will precipitate this manifestations of acute intermittent porphyria is alcohol, steroid hormones, those who are alcoholic who are taking steroid hormones or OCPs, and during fasting or starvation, any infections in the patient, any stressful conditions, and drugs like barbiturates, sulfonamides, progesterones, anticonvulsants, and in some of female patients because of the regular cycling menstrual cycle, AFP can also be precipitated. So what happens? Why it is getting precipitated during puberty or during a menstrual cycle is because there will be a variation in the steroid hormones during puberty, which will induce the ALAS1 enzyme. So what happens? ALAS1 enzyme is an enzyme which will convert porphobilinogen to hydroxymethylbilin. So because of this, there will be more production of its precursors porphobilinogen. So there will be precipitation of symptoms. So drugs and steroids will require cytochrome P450. So that will also precipitate. So more of requirement will lead to increased production and increased accumulation. That is the mechanism. So excessive utilization of cytochrome P450 for which heme is utilized leads to a relative diminution of heme in the cells, which causes de-repression. That is, ALA synthase enzyme will be repressed normally. So when there is decrease in heme in the body, there will be de-repression of ALA synthase enzyme. So in fasting, what happens? Increased expression of peroxisome proliferator activated receptor gamma coactivator 1 alpha leads to increased ALAS1 transcription and increased heme synthesis, and by virtue of it, there will be increased porphyrin synthesis. So what do they say is, during fasting, there will be precipitation of porphyria, and when there is increased carbohydrate intake, it will ameliorate the attack, that is, decrease the severity of attack. So hepatic, this PGC1 alpha induced by fasting will activate ALAS1 transcription. So if the glucose is given during a high carbohydrate intake diet, the specific enzyme PPGC1 alpha will be inhibited. What are the clinical features? Clinical features are acute abdominal pain because of excitation of visceral pain fibers, vomiting, tachycardia, hypertension, sensory motor disturbances, confusion, and abrupt change in mood, hallucination, anxiety, depression, etc. And peripheral neuropathy, convulsions due to hyponatremia. And as you know, as I have already discussed, acute attacks are more common in females than males. And there are less severe manifestations before menarche and after menopause. So what happens because of the inhibition of HMB1 synthase enzyme, ALA and PBG, the precursors ALA and PBG will accumulate, and these are neurotoxic. Why? Because ALA has got a similar structure as that of neurotransmitter GABA, and this ALA autooxidation will generate reactive oxygen species, which will destroy the brain matter. So this is responsible for the neurological symptoms. And CNS involvement is also due to heme deficiency in the liver, which will interfere with synthesis of neurotransmitters. So the actual neurotransmitter which has to do the action in the brain is not synthesized. Rather, ALA, which has got a similar structure, will be present inside the brain matter, and it will auto-oxidation will result in generation of reactive oxygen species. And neuropsychiatric disturbances is mainly due to reduced activity of tryptophan pyrrolase, which is caused by depleted heme levels, which results in accumulation of tryptophan, serotonin, tryptophan, and serotonin 5-hydroxytryptophan. Why there is no photosensitivity is because The metabolic block will lie early in the pathway. So the porphyrin ring structure, which is responsible for proteinase photosensitivity, is never formed at all. So high in the pathway, there is a block. So the photosensitive material or compound which is being synthesized in the lower pathway is not being synthesized at all. So this porphyrin, when exposed to light at 400 nanometer, will get excited and react with oxygen to form reactive oxygen species, which will damage the cell components. So the degradative enzymes released from the lysosome will cause skin injury, leading to photosensitivity. What are the complications? Sudden death because of sympathetic overactivity, and treatment of seizures is also difficult because anticonvulsant drugs will precipitate AIP, acute intermittent porphyria. What are the long-term complications are? Chronic renal failure, hypertension, and hepatocellular carcinoma. How do you diagnose AIP? AIP is mainly diagnosed based on the clinical features, characteristic clinical features. And then when you look for urine and plasma, ALA and PBG levels, they are substantially increased during acute attack. So here you can see a box where it will give the normal urinary porphobilinogen excretion and ALA excretion. So after IV heme administration, these excretion will get decreased. ALA and PBG are elevated. So because of this, urine will get darkened on standing for a longer time. When kept at room temperature, it will get darkened due to photooxidation. Urine also will get darkened on exposure to air due to conversion of porphobilinogen to porphobilin and porphyrin. The mechanism behind darkening of urine. Fecal porphyrins are usually normal or minimally increased in AIP. And we have to screen the family members to diagnose asymptomatic family members. How do you manage it? Symptomatic treatment only. Drugs and provoking agents should be withdrawn. Opiates will give pain relief. For hyponatremia, IV fluids. So carbohydrate-rich supplements so that it will ameliorate the alaskan transcription. IV heme or heme conjugates. Ingestion of beta-carotene and suppression of ovulation in women with cyclic premenstrual attacks by GnRH analogs. And now we have got advanced treatment modules, which includes hepatic targeted RNA interference therapy and liver directed gene therapy, all these things. Next disease is ALA dehydratase deficient porphyria. It is very rare and it is autosomally recessive inherited, and there is a mutation in ALA-D gene. Enzyme deficient is ALA dehydratase enzyme. So ALA is not getting converted to porphobilinogen. It is also called as DOS porphyria. Commonly affects male adolescents as compared to AIP, which affects mainly females. And symptoms will resemble AIP, abdominal pain and neuropathy. So in babies with more severe disease, they will have failure to thrive from birth. How do you diagnose? There will be significantly elevated levels of plasma and urinary ALA and urinary coproporphyrin. And there will be decreased levels of erythrocyte ALA dehydratase activity. We have to confirm the diagnosis by mutation analysis and also by prenatal diagnosis by ALA dehydratase activity in cultured chorionic villi. These are the differential diagnoses: hereditary tyrosinemia type 1, lead poisoning. How do you treat it? Acute attacks are treated similar to like symptomatic treatment, similar to that of AIP. And the most advanced thing we can do in case of ADP is liver transplantation. Third one is hereditary coproporphyria, inherited as autosomal dominant, and there will be mutation in coproporphyrinogen oxidase gene. So coproporphyrinogen 3 will not get converted into protoporphyrinogen 3. This disease also present with acute attacks, but it is less common than AAP. What are the clinical features are? They are similar to AAP. They'll have abdominal pain, vomiting, and cardiovascular symptoms. Cutaneous photosensitivity sometimes may occur. They have blistering skin lesions, and this disease also is later before puberty, identical to AIP. Coproporphyrinogen 3 is markedly increased in urine and feces in symptomatic patients, and urinary ALA and porphobilinogen levels are increased during acute attacks, but when symptoms get resolved, it will revert back to normal. Plasma porphyrins are usually normal, sometimes increase when the patient has got skin lesions. If you look for plasma porphyrins, it will be increased. Diagnosis is by confirmed by increased fecal porphyrins. Lab findings in urine, porphobilinogen will be more than ALA, and coproporphyrin 3 and uroporphyrin will be increased. In fecal, coproporphyrin 3 will be increased. How is it treated? Again, acute symptoms are treated similar to AIP. Intravenous hemin, gabapentin and levetiracetam for seizures are safe. Liver transplantation and renal transplantation for patients with renal failure. Fourth category is variegate porphyria, which is autosomally dominant, and there will be mutation in PPO, porphyrinogen, protoporphyrinogen oxidase gene. So protoporphyrinogen 3 will not get converted into protoporphyrin, and because of this, heme is not synthesized. So all of the intermediates of heme synthesis, which is prior to this step, will be accumulating in the body and excreted in urine and feces. So clinical features include both skin photosensitivity and acute neurovisceral attacks, and acute attacks are identical to those in AIP, and it is precipitated by same factors as in AIP. So blistering skin lesions will be present, which is of longer duration, and they are very difficult to treat. Homozygous variegate porphyria, it is associated with photosensitivity and neurological symptoms, and there will be growth retardation and developmental disturbances in children or during infancy. How do you diagnose this variegate porphyria? Increased urinary ALA and porphobilinogen during acute attacks, and which will revert back to normal once the symptoms resolve. And there will be increased fecal protoporphyrin and coproporphyrinogen 3. And there will be increased coproporphyrinogen 3, and which is also more persistent. Plasma porphyrin levels also increase, particularly with cutaneous lesions. And it can be distinguished rapidly from other porphyrias by examining the fluorescence emission spectrum of porphyrins in plasma. It has got a unique peak at neutral pH. Increased erythrocyte levels of zinc protoporphyrin. How do you diagnose in lab? In urine, there will be more of porphobilinogen than ALA. Coproporphyrin 3 and uroporphyrin will be increased. In fecal, protoporphyrin 3 will be more than coproporphyrin. Plasma porphyrin fluorescence, a unique peak at 6 to 24 to 6 to 28 nanometer. The next is treatment. How do you treat it? Again, similar acute attacks are treated as in case of AIP, and avoid sun exposure and application of beta carotene for treating skin lesions and liver transplantation. The next category of porphyria is, now we'll see how to differentiate acute porphyrias. So these three are the three acute porphyrias: acute intermittent porphyria, hereditary coproporphyria, and variegate porphyria. In AIP, urine porphobilinogen will be more than ALA. In hereditary coproporphyria, fecal coproisomer 1 is more than 3. And variegate porphyria, there will be a specific fluorescent peak of plasma porphyrins. The next category of porphyria is Porphyria cutanea tata. It is an autosomally dominant inherited disease. There will be mutation in uroporphyrinogen 3 decarboxylase gene, which will encode for uroporphyrinogen 3 decarboxylase gene, and it is the most common porphyria. Hence, uroporphyrinogen 3 is not converted to coproporphyrinogen 3. There are three types: sporadic or type 1, familial or type 2, and type 3. Type 1 is uroporphyrinogen 3 decarboxylase deficiency, will be observed only in hepatic cells, and genetically individuals will not exhibit any deficiency in the gene. Deficiency in HFE gene will play a key role. Type 2 is familial. It is an heterozygous mutation of uroporphyrinogen 3 decarboxylase. Only a deficient form of enzyme will be seen, and the expression of this gene will be reduced throughout all the cells in the body. And in type 1, it is confined only to liver. Type 3 is the least common type. They'll possess normal urode genes, but despite this, type 3 Porphyria cutanea tata is observed in more than one family member. What are the precipitating factors? Inherited urode mutations in type 2 Porphyria cutanea tata hepatitis C, HIV, excess alcohol, elevated iron levels, hemochromatosis, estrogens, hemochromatosis gene mutations after exposure to halogenated aromatic hydrocarbons. How PCT is associated with hepatitis C is the cytopathic effect of the virus on hepatocyte can lead to release of free ion, which this free ion can disrupt the activity of cytochrome P450, releasing activated oxygen species. So these can oxidize the Euro-D substrate uroporphyrinogen, which can result in inhibition of Euro-D enzyme. Cutaneous photosensitivity. It is mainly due to accumulation of porphyrinogens in the skin, which results in conversion to porphyrins by light. This porphyrins will react with molecular oxygen to form oxygen radical, producing severe damage to the skin. So there will be blistering skin lesions mostly in the backs of the hands, and this will rupture and crust over, leaving atrophic scarring areas. And these lesions may also be seen in forearms, face, legs, and feet. And there will be fragile skin, and small white papules called as milia on the back of hands and fingers. Hypertrichosis, that is more of hairs, and hyperpigmentation, especially on the face. And the sun-exposed area skins will become thickened with scarring and calcification. And neurological features are mainly absent in this type of porphyria. So here you can see blisters, which in turn will lead to this type of scarring. And pigmentary changes, hypertrichosis. Hallmarks of PCT are blisters leading to ulceration, fragility, hyperpigmentation, and hypertrichosis on the sun-exposed areas. So it is an acquired form of PCT because of a fungicide. Lab findings is urine ALA and TPG. The precursors are not increased. Urine porphyrins which are seen are uroporphyrinogen and heptacarboxylate intermediate. In feces, isocoproporphyrin and heptacarboxylate intermediate. How do you treat it? Alcohol, estrogen, and iron supplements, and if possible, the drugs which will precipitate the disease should be discontinued. Avoid sun exposure and sunscreen to absorb the UVA. Repeated phlebotomy to reduce the hepatic iron. Chloroquine and hydroxychloroquine to remove excess porphyrin from liver by increasing their excretion in urine. The next category is erythropoietic porphyria. It's congenital erythropoietic porphyria due to uroporphyrinogen 3 synthase enzyme deficiency, and erythropoietic protoporphyria due to ferrochelatase enzyme deficiency. Congenital erythropoietic porphyria is an autosomal recessive inherited disease, mutation uroporphyrinogen 3 synthase. So hydroxymethylpyrin is not converted to uroporphyrinogen 3. It is a rare congenital disorder, and individuals will excrete uroporphyrinogen 1 and coproporphyrinogen 1, which will oxidize respectively to uroporphyrin 1 and coproporphyrin 1. And this will result in their accumulation in bone marrow and erythrocytes, and will in turn result in hemolytic anemia and some cutaneous lesions. Clinical features are severe cutaneous photosensitivity, typically begins in early infancy. Skin over light exposed areas is friable, and bullae and vesicles can be seen, which are prone to rupture and infection. Secondary infections of these cutaneous lesions lead to disfigurement of face and hands, and hemolysis due to increased erythrocyte porphyrin, leading to splenomegaly. Port wine urine, pink stain in diapers, porphyrin gets deposited in teeth and bone, and resulting in erythrodontia. They are brownish teeth that will produce a red fluorescence in UV light. And with age progressing, scarring and similar lesions similar to that of PCT will happen. Atrophic changes which leads to photomutilation with erosion of terminal phalanges, destruction of ear, nose, and iris that will mimic leprosy, and alopecia. So here you can see brownish discoloration of teeth and erythrodontia, red fluorescence in UV light. Deposition of porphyrins in teeth and bone. Teeth, you can see brown teeth. Erosions of terminal phalanges, you can see, and mutilated nose, ears, alopecia, and And diagnosis is mainly by accumulation of type 1 isomers of uro and copper porphyrin in bone marrow, RBCs, plasma, urine, and feces. And diagnosis is confirmed by demonstration of markedly deficient urosynthase activity and identification of specific mutations in urose gene. Prenatal diagnosis can also be done by analyzing porphyrin in amniotic fluid and urose enzyme activity in chorionic villi and cultured amniotic cells. Treatment for congenital erythropoietic porphyria is severe cases will require transfusions, frequent transfusions for correcting anemia. Splenectomy will reduce the chance of hemolysis and decrease transfusion requirements, and protection from sunlight and skin trauma, beta carotene, and treat the complicating bacterial infections and gene therapy. Erythropoietic protoporphyria is an autosomal recessive disorder, and there will be mutation in ferrokeratase gene. So ferrokeratase enzyme will be deficient. So protoporphyrin 3 will not be converted to heme. It is the most common in children and second most common porphyria in adults. There will be elevated levels of protoporphyrin in blood, bile, and feces. Clinical features are non-distinct skin photosensitivity associated with substantial increase in erythrocyte protoporphyrin. It consists of pain, redness, swelling, itching within 8 minutes of exposure to sun. Vesicle lesions are uncommon. So you can see erythema and edema of hands in erythropoietic protoporphyria. It is relieved by plunging their hands in water or covering by wet towels. Absence of fragile skin, hypertrichosis, and subepidermal bulla differentiates this disorder from other porphyria. Complications are progressive hepatic failure due to accumulation of protoporphyrin, polylithiasis because of high concentration of protoporphyrins in the bile. So how do you diagnose this? Is substantial increase in erythrocytic protoporphyrin, which is predominantly free, and it is not complexed with zinc, is a hallmark of erythropoietic protoporphyria. And protoporphyrin levels will increase in bone marrow, plasma, bile, and feces. And in a suspected case, confirm the diagnosis by assay that distinguishes the free from zinc complex protoporphyrin. Erythrocytes will exhibit a red fluorescence under fluorescent microscopy at 620 nanometer, and there will be decreased ferrokeratase activity in cultured lymphocytes of fibroblasts, and FEC mutation diagnosis by mutation analysis. Erythrocyte protoporphyrin concentration will be increased in other conditions like lead poisoning, iron deficiency, hemolytic disorders, other forms of porphyrias. But in all these conditions, it is complexed with zinc, whereas it is free in EPP. Lab findings between CEP and EPP are urine porphobilinogen is not increased in both types of porphyria, whereas in CEP fecal coproporphyrin 1 will be increased, urine uroporphyrin 1 and coproporphyrin 1 will be increased, and in erythrocyte zinc protoporphyrin, coproporphyrin 1 and uroporphyrin 1. Whereas in EPP, erythropoietic protoporphyria, fecal protoporphyrin will be either present or absent, but urine it is not increased. Erythrocyte free protoporphyrin, not complexed with zinc. Prognosis and complications, there will be biliary fibrosis, chronic liver disease, and progress to liver failure and death. Treatment is avoid sunlight exposure, wearing clothes to provide protection, oral beta carotene, and MSH hormone. It is under trial. And splenectomy in case of hemolysis, plasmapheresis, IV heme, liver transplantation, bone marrow transplantation, and other porphyrin absorbents are given. Acquired porphyrias are lead toxicity due to lead toxicity, arsenic, alcohol ingestion, and other heavy metal ingestion, chronic renal failure, liver disease, iron deficiency, anemia, and hematological disorders. So lead will inhibit the enzyme here, synthase enzyme and ferrokeratase enzyme. Sorry, aldehyde enzyme. What are the tests for porphobilinogen? Ehrlich's test, Watson-Schwarz test, and test for total porphyrins in urine spectrophotometry, in feces against spectrophotometric estimation, and in erythrocytes and plasma, fluorescence on spectrophotometry. And these are the laboratory tests for porphobilinogen in urine. Urine specimens should be fresh and there shouldn't be any preservative. If the testing is delayed, specimen is stored in 4 degree in dark where it is suitable, stable for 48 hours, and in minus 20 degree, it is stable for 1 month. And urine may darken if left at room temperature. And these are some of the tests you can you'll be reading in your practicals. So with this, Porphyria is over. Thanks for patient listening.